Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Ryan Topping. Today's episode features Dr. John Mascarenhas from the Icahn School of Medicine at Mount Sinai in New York City, and Dr. Ruben Mesa from the Atrium Health Wake Forest Baptist Comprehensive Cancer Center in Winston-Salem, North Carolina. They will be discussing current best practices and emerging approaches for treating patients with myelofibrosis. This episode is part of a larger educational program titled Integrating Current Evidence and Individualized Treatment Regimens into Clinical Practice for Patients with Myeloproliferative Neoplasms. Please visit the show notes for this episode for a link to the complete program, including expert commentaries, an interactive treatment decision support tool, and additional podcasts. Now, let's get started and hear what the experts have to say.
Hello, my name is Ruben Mesa, and I'm the Executive Director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center, and excited to have you join this program between myself and my good friend Dr. John Mascarenhas on contemporary issues in treating patients with myelofibrosis. John, why don't you say a couple words of introduction?
So, Ruben, thanks for having me. My name is John Mascarenhas. I'm a professor of medicine here in New York City at the Mount Sinai School of Medicine, and thrilled to join you on this topic.
Wonderful. Well, let's jump right in. So, as we think about treating patients with myelofibrosis in 2023, we still fundamentally have the same key pathway. We identify their risk or their prognosis using a modern scoring system, of which there are many. I tend to use a MIPSS 70 most often, with perhaps some variability for post-ET or post-PV MF. Consider their disease burden, symptoms, splenomegaly, how much are they suffering with the disease? Then move on to medical therapy or stem cell transplantation. John, what does that core medical therapy briefly look like in 2023?
So, as you mentioned, it's really an assessment of the spleen and symptom burden and attention to the platelet count. So, for those patients that are in need of reduction in that spleen and symptom burden, the first line of therapy remains a JAK inhibitor. If the platelet count is less than 50,000 by label, pacritinib is the JAK inhibitor of choice to address spleen and symptom. And if the platelet count is greater than 50,000, one would typically use ruxolitinib up front, although the label for fedratinib would also allow first-line option as well. So we use JAK inhibitors to address these burdens that these patients may have, with the understanding that we will not induce pathologic remission or molecular remission, and we need to have a treatment paradigm set in place in which we're considering loss of response or refractory disease and second-line options.
Wonderful and well put. For those that have not yet prescribed pacritinib, it was approved approximately a year ago. It's a JAK2 and FLT3 inhibitor. It also inhibits IRAK1 as well as ACVR1. And it's somewhat unique profile from early days when we began testing it was the ability to give it in individuals even with marked thrombocytopenia. And this slightly different kinome pattern of inhibition may be part of that story. Indeed, it's very helpful in those cytopenic patients with myelofibrosis. It can be given at full dose, irrespective of platelet count, at 200 milligrams twice a day, as well as there can be anemia responses in some individuals, even becoming transfusion independent, based on perhaps this inhibition of ACVR1. So that's really been an important addition to the treatment paradigm. Now, John, you had mentioned fedratinib as well, which is a good medicine. It certainly has an important role. In which patients are you thinking of the use of fedratinib in 2023?
The patients I would consider are those who have been on ruxolitinib and perhaps continue to have spleen or symptom burden and platelet count greater than 50,000. Those are excellent candidates for fedratinib, which I agree is really probably a underutilized JAK inhibitor today, and should be considered for those patients in which you're looking for a second-line agent and switching someone from ruxolitinib to fedratinib.
I think you raise an excellent point. It's an agent that, I'll be honest, has been underprescribed at this point. It has very solid data from the Jakarta and the Jakarta 2 study. It clearly can be beneficial in the front line or second line. And I think where people are missing an opportunity is really in the second line. When individuals have adequate platelet counts, the data in both the front and second line studies are good. Now, one needs to be mindful of thiamine levels. There is a black box warning, although it's quite manageable to avoid a very low risk of Wernicke's encephalopathy that's largely able to be avoided with proper tracking of thiamine or replacement. There can be some GI toxicities that need to be managed, but it's a good drug. And for patients who need second line therapy, they have a big spleen, they have lots of symptoms, they don't have a good clinical trial option. Again, a very important consideration. Now, we're well over a decade after ruxolitinib has been approved, and it has really been a game changer. Having been involved with caring for these patients for many decades, the JAK inhibitors and ruxolitinib really transformed the face of MF. Patients live longer, they live better. We clearly still have a room to go, but no one should minimize how impactful that has been. Not only in terms of improvement in spleen and symptoms, but patients clearly live longer, probably for a range of reasons. However, we know that it is not a cure and that patients can both fail ruxolitinib, and over time, patients do tend to come off ruxolitinib, but that sometimes has been as much as being on therapy for well over a decade to perhaps more average to 3 to 4 years. Now, John, how do you think treating physicians should be defining ruxolitinib failure at this time? I know as academic investigators, we sometimes have struggled to really define that in a reproducible way.
It is sometimes hard to define because it's not always black and white. And it's one of those things when you see it, you recognize it, but sometimes it's gray. And sometimes failure could be an initial response of splenomegaly and then some increasing spleen over time at a maximally tolerated dose of ruxolitinib. Sometimes it's what I would call symptom creep. You have a great response initially and the symptoms start to come back. And sometimes it's frank progression of disease to acute leukemia, myelofibrosis of blast phase. And in about a quarter of the patients, it might just be simply toxicity, like suppression of the counts or infectious complications. So one needs to sort of be aware of the patient and the spleen and symptom response or loss of response, the blood counts, and the potential for progression of disease despite having spleen and symptom control. And by median about 3 years, half the patients are off their first-line ruxolitinib treatment for a variety of these reasons I've discussed. And it really begs the point that one needs to plan ahead and have a second-line option geared up for that patient.
So you relayed several unmet needs in myelofibrosis, particularly as it relates to potential loss of response or failure with ruxolitinib. We had previously talked about thrombocytopenia and the benefits with pacritinib in that space. What are some other unmet needs?
So I would say largely the unmet need remains remission and prolongation of survival, but also cytopenias and improvement in cytopenia. So there are a fraction of patients you'll meet up front where perhaps their spleen and symptom burden is not the goal of therapy. Maybe it's anemia, and there's a algorithm for addressing anemia, whether it's a erythropoiesis stimulating agent, danazol, an immunomodulatory drug, or even the activin ligand trap luspatercept. But I would say collectively you have about a 30% response rate with each agent, and often you run through those drugs and are still left with someone who has ongoing anemia. Or the anemia could be in the setting of being on a JAK inhibitor and trying to alleviate anemia in addition to spleen and symptom control. So there still remains a significant unmet need in the form of cytopenias, and what I would still say are true disease course modifying drugs that change the natural history of the disease.
I think well said. Fortunately, I think we see clearly benefit coming to patients on the horizon. So as we pivot to talking about new therapies, first I'll discuss momelotinib. This is a JAK2 and ACVR1 inhibitor. It's been shown in earlier studies to be able to improve spleen symptoms and anemia. I was involved with helping to lead both the Simplify and the Momentum study. And in the most recent Momentum study, this was second-line symptomatic patients, failed Rux, and were anemic. And the drug was clearly superior to danazol, improving spleen and symptoms, and non-inferior for improvement in anemia, although it was certainly trending toward being statistically superior. But it met all of its key trial endpoints, and both with safety and efficacy, and really was able to treat that whole portfolio of individuals. I think combined with favorable frontline data from Simplify 1, momelotinib is likely to get an approval in the near future, at least in the second-line setting and probably in the frontline setting, with, I think, in particular consideration around patients that have significant anemia. Now, John, you had mentioned multiple combinations and the goal of more disease-modifying therapy. I just came from this weekend from a heme review meeting, again, seeing the data being presented in lymphoma and CLL, myeloma, the acute leukemias, and it certainly strikes me that there are very few diseases, perhaps with the exception of CML, that we continue to treat with monotherapy. So combination therapy seems natural. In myeloma, I think they largely are moving to 4-drug therapy. And again, these are diseases with complex biology. It's logical to think that combinations may be helpful. Which of those combinations do you think might be most impactful? How might they be used? Do you think they'll be disease modifying?
Well, I certainly hope they'll be disease modifying, and we'll have to see what the ongoing randomized phase 3 studies show. The ones that to note would be the upfront combination of ruxolitinib and pelabresib, the pan-BET inhibitor and JAK inhibitor naive patients, with the goal of improving spleen and symptom benefit and hopefully prolonging duration of ruxolitinib benefit. The other two drugs that are also notable would be parsaclisib, the PI3 kinase inhibitor, which is being evaluated upfront and second line, although I believe the second line study has been discontinued, and navitoclax, the BCL2-XL inhibitor, both again upfront and second line as combination. I think the theme of adding an agent to ruxolitinib that would likely synergize based on preclinical data, hopefully avoid some additive toxicity and increase the durability of spleen and symptom benefit, perhaps even attain other benefits that we like to talk about that may be disease modifying, such as reduction in bone marrow fibrosis, inflammatory cytokines, or driver mutation burden, are all aspects that we look at these days. However, it is paramount that these studies correlate those disease modification biomarkers with actual disease course modification, whether it's prolongation of progression-free survival or ideally overall survival.
You know, I think you raise a range of exciting things coming down the pike. Indeed, we probably have more phase 3 studies at the current time for myelofibrosis than we've ever had before. For folks listening to this, I would view them in a few different buckets. You know, one, you have combinations or approaches that really may be helpful with aspects of disease, such as the addition of luspatercept to ruxolitinib really in the face of anemia. And again, then we'll be considering in the setting of the anemic patient, do we use momelotinib? Perhaps if they're also thrombocytopenic, do we use pacritinib? Do we use luspatercept, particularly if they have an SF3B1 mutation or some other aspect? Two, we're going to have, you know, numerous combinations that if they have positive phase 3 studies, I think we're going to really look long and hard to see in which do we use which patient. Pelabresib looks, I think, very exciting, navitoclax, but certainly, you know, several others of these as well, you know, and new therapies even around the corner, potentially calreticulin mutated antibodies that will be targeted. John, maybe in the final moment that we have, what are you most excited about kind of for the future for our myelofibrosis patients?
Well, I'm definitely excited for a future where we're going to utilize rational combination therapies, and we've listed a number of them that look promising. Perhaps non-JAK inhibitor-based therapies like imetelstat for prolongation of survival, navtemadlin for deeper, more durable responses. So I do see a future of redefining disease modification and clinical course, and obviously that's an exciting time for us as clinical investigators, but hopefully meaningful for our patients with myelofibrosis.
You know, I think you're exactly right. I think we'll have more options, and I think as we are trying to better tailor therapy to meet an individual patient's needs. The correlative studies from these phase 3 studies, I think, are going to be very important, as well as subgroup analysis. If we have all things equal and we have 3 options, how do we best guess to which therapy that we will utilize? What are our metrics of success? I think it would also lower the bar for us to consider a change in therapy if we see an inadequate response. So on behalf of my dear friend and colleague, John Mascarenhas, and myself, thank you so much for listening to this podcast. We hope that you have found this helpful. Thank you.
Thank you very much, Dr. Mascarenhas and Dr. Mesa, and thanks to you, the listeners, for joining us. As a reminder, to view the full educational program on the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.